the time, and I'm very happy to be here to just share few thoughts about the technology, what Anuprita is going to speak. And yes, we are working on this since very long from now, and I must thank you for like creating such a good platform and like making it aware to the entire neurophysiotherapy group or the entire almost the country to know about this one. And your selfless efforts will definitely face us a good result. So I congratulate you and thank you for giving this opportunity. And I'm also thankful to Anuprita, and she's working with me. She was my student here, and then she was doing her doctorate in Canada and German and all those. So it's a very good speaker with us. So she's the master for getting this part in this part of the country. And so I'll be discussing because anything we want to do, I think we need to answer three questions. The first question is why I should do this. The second question is what I should do. And third question is how should I do? So probably I wanted to talk about why we should go for a technology. Okay, next slide. Yeah, so that's brief CV about me. Next slide. Yeah, so what I'm going to discuss is majorly about, I'm just switching off my video so that I can get a good width. So what I'm going to discuss is how does the pediatric physiotherapy is, and I can correlate this with even a neurophysiotherapy also. So those who are working in adult areas can also correlate this particular talk very clearly. But I wanted to ask you one question before I start is, whenever I'm going to discuss this, you please remember any one patient. I'm going to give you example of one patient. And that patient example is all of us have seen right from our undergraduate to postgraduate or practice is a hemiplegic hand. In a spastic stage, the person who is standing, who is having an upper extremity with adduction at shoulder, internal rotation, elbow flexion, pronation, and wrist flexion with the thumb in palm. If I ask you what treatment we gave or what treatment we are giving, then most of us we do is we outstretch the hand, we put the weight on that particular hand, and we hold that elbow and give the weight bearing to the upper extremity. Keeping this particular treatment in mind, I'll discuss the further thing. Similar story we do with the pediatric also. I wanted to ask all of you when I discuss this, which therapy are we giving to our patients? Are we giving a therapy of yesterday? Are we giving a therapy of today? Or are we giving a therapy of tomorrow? Okay, so that's what my focus is. And I'll be brief and be specific to my points. If you have any queries, you can ask me later. Next slide. Yeah. So most of the time, the first thing comes in the mind whenever we pediatric physiotherapy, we say, then only one condition people thinks of, and that is cerebral palsy. But let me tell you, the pediatric physiotherapy doesn't stop there. It has a very vast role in cardio, respiratory, obesity, orthopedic conditions, and of course, neurological conditions. And in neurological condition, cerebral palsy is not the only condition. There are many other conditions, and probably now, if you ask me, the cerebral palsy prevalence is reducing, in fact, and the other disorders are becoming more and more common. Okay, next slide. So, if I go back to the yesterday, like what was the therapy we were giving to the children? So, previously in the 1948, 49, 52, and so on, during that particular time, we were giving a approach of Phelps. That was majorly we were focusing on muscle education, and we were giving them more of braces. And this particular approach was developed by Jenny Colby, who was a gymnast, and we were giving a lot of active movement exercises. Okay, next, and a lot of massage we were giving, and we were using some of those modalities there. Okay, next. Keep clicking, Anuprita. So then we were using a lot of wheelchair. Then we were using a lot of orthosis. Then we were going for, we came to a conclusion or a thought where that we decided that no, we are going to treat them as per the development in evolution. And we started following ontogenic and phylogenetic development. And then we started coming to specific problem in muscle. Okay, I wanted to stress here, we were focusing a lot on a specific problem in the muscle. We started with giving them alcohol injections, and we advocated early orthopedic surgeries for these children who were suffering from neurological deficits, majorly for a cerebral palsy. Okay, next. Then we moved from there and we started using inhalation of CO2. We told that we need to restrict the fluid to get the development. We started putting them upside down, and we advocated that we should have a passive physiotherapy most of the time. From there, we moved on to the early treatment, which was given by Iron Collis. And we told that no, 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 whenever we are going to treat our children, we are going to follow a strict developmental sequence that is proximal to distal. It should develop first, and then the neck, then the trunk, and then the legs. From there, we moved towards the broomstone, and we thought that no, no, we have to initiate some amount of reflexive response, and that reflexive response will turn to be voluntary movements. From there, we further moved to the group therapies. We thought that we need to do this as an all day program, and we need to treat them individually also. Next slide. So I wanted to get back to here. Remember the patient uh, component, what I told you, that we are holding a patient's hand, a patient with a spastic hemiplegic hand. And what we have done is we outstretched it, we put the weight, we kept the wrist in extension, we got the thumb out, almost we sit on their hand, and we kept the elbow in extension. Now I wanted to think about this short history of medicine. I just finished what was given in 19th century up to 1950. Now I wanted to take you to this history. First, when a patient came in the medicine history, he asked with the earache. In 2000 BC, doctor told that you please take this root. In 1000 AD, they told that the root is Eden. So the doctor said that, okay, you say this prayer. In 1850, they said that, no, no, prayer is superstitious. Then they gave a drink poison. Poison means a medicine. Then they said, no, the poison is like a snake oil. Then the doc said that, no, no, you swallow this pill. Now, 1950, they said that the pill is ineffective. Then the doc said that you take this antibiotic. Now, 2000 AD, we are saying that the antibiotic does not work anymore. So, are we saying eat this root again? So, are we going back to the 2000 BC? I just wanted to bring you here physiotherapy. So, we started with a passive movement. We started with understanding that it's a muscle re-education program. We started with saying that no, 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 we have to give a lot of passive support in the form of orthosis and the wheelchairs, give them the alcohol injections, or do the early surgeries. So if I follow this particular pattern for a physiotherapy, am I going back to the passive movement in today's era, or I am stuck at the pill, that is means at the approaches? And if I'm using the approaches, which approach I am using? Am I using approach which was spoken to us yesterday, or am I using the approach which is spoken to us today, or am I thinking of tomorrow, considering the patient as a center point for me? Okay, so take you towards the next portion of this. That this is what was spoken till 19th century to 1950, and this is what was spoken about the medicine what we are taking today. So from there we move towards the reflex creeping. Very well, everybody knows about the Vita. What Vita was focusing is that we have to use certain points, press them, and get some amount of reflexive movement. So they were like reflex creeping, reflex rolling, sensory stimulation. So these components, and then when they're moving, we were trying to giving them resistance. So remember that he was told us to work on a reflexive pattern. There is a stimulus, there is a response. So there is a reflexive pattern was asked us to develop. Next. Now, just think of this particular condition. I think all of us have seen this polio. You see on the upper picture what we have done for a polio. We gave them the crutches, we gave them the orthosis, we made them walk in the parallel bar. Okay. So Now, that was happening from 1350 BC to 1894. Now, please remember your child who is with cerebral palsy. Aren't we giving them this, that is passive range of motion? Again, we are fixing them with hip, knee, ankle, foot orthosis. We are doing stretching. We are giving them those crutches. So, think, am I still doing a muscle re-education? Am I doing the muscle re-education? If I am doing the muscle re-education, which era therapy I am using? Okay, next slide. So I will take you from there to what are the approaches for speaking about today. Okay, and you have to remind yourself which approach are you using? Are you in yesterday, before that, today, or tomorrow? Next slide. So you see in the polio, we did this. In the cerebral palsy, we are doing this. Okay, next. So the question over here is, the disease has changed, but therapy has remained same. Whereas LMN is a polio, CP is a human, but shouldn't we treat them separately, or should we treat them same? If you are treating them same, then the disorder is not same, right? Next. So from there, we moved on towards the PNF, and sir is master of this one. So we started using the PNF in today's practice. We do that. Next. Then we lot of think about the our roots approach, which talks mainly about that we should follow a sequential pattern of development. That's what I said, like head control first, then the trunk, and then the leg. And this is the 8 positions what they give. So basically, this all these approaches were based upon the previous what I spoke were based upon just muscle re-education, whereas this PNF or the roots were based upon the reflex hierarchical theory. Okay, next slide. From there, we move towards, and there is a lot of talk about this, that is neurodevelopmental therapy. Just in a few sentences, neurodevelopmental therapy, what's used now, and the NDT, Bobath, what's given previously, both are little different. The previous one believes more about reflex hierarchical theory of motor development, whereas the recent neurodevelopmental therapy believes more on the dynamic system theory and neuronal group selection theory. So presently we do use this, but the concept of using this has changed from reflex hierarchical to the dynamic system and neuronal group selection theory. Okay, next slide. We do use this sensory integration a lot. Previously, I mean, originally it was given for children with LD where there is no neurological deficit known in the brain, but it has been getting into a lot of into the practice, stating that it does help in the cerebral palsy children. It does help. Definitely, it helps in autism also. So we do use in today's practice this also. Next slide. So if I am using NDT, if I am using sensory integration, and if I am using, or am I using the muscle re-education? The question is to all of you, for that outstretched hand, what we put out and what we did. Basically, by doing an upper limb weight bearing, it's not against the upper limb weight bearing, there is a way to do it. But am I focusing on muscle re-education? Am I doing reflex inhibiting pattern, which was given by Bobath? Or am I doing something which is spoken now about the motor control theory, where there are multiple systems comes into the action for one particular problem? Or I am doing something else which has no evidence or which has no theoretical foundation. Okay, next slide. So again, I'll come back here and ask you, where are we? Are we again moving back to the root by doing a passive? Or have we stuck at antibiotics? Or we have stuck at pill? That means, are we still stuck into the approaches? Are we moving out of the approach? Or are we going towards the passive? Where are we moving? Next slide. So if you look into all those approaches which have been discussed, your old NDT, VOETA, they all, or your milestone development, they all are based on a reflex hierarchical theory. Means the lower centers, once the lower centers will be there, there will be higher centers. And once there is a problem with the higher centers, lower centers will behave the way they want. That's why we see spasticity. That's why we see dot synergies. And when I go away from that synergy, I do something opposite to that synergy. I'm actually using a reflex inhibition, which is based on a RIP, or sorry, which is based on a reflex hierarchical theory. So where am I? Am I in a muscle re-education, or am I in a yesterday, or am I moving towards today and tomorrow? Okay, next slide. So presently, this is what we use: NDT, SI. We do use hand-up bimanual intensive task therapy. We use hydrotherapy. We use hippotherapy. By using these today's approaches, are we really using it, and how much are we using it? Are they really enough for us? Are our patients' problems are getting solved? Are they getting more better than or versus using those RIPs or those muscle re-educations or those alcohol injections or those early orthopedic surgeries? Have I moved my patient from point A to point B little better, better quality of life, better quality of movement by using what has been spoken now, that is habit, hydrotherapy, hippotherapy, and so on. Okay, next slide. So why there is a chance for us to get into the next thought and get out of the thought where we still go on to the muscle re-education. Because as I showed in my slide, muscle re-education is basically for patients who are having a polio, whereas treating a brain through your movement is actually you're treating on a brain lesions. Otherwise, you will not treat the brain lesions. So individual muscle activations, individual muscle inhibitions has evidently no role much. Whereas using the recent means it has been supported by a motor control theories like dynamic system theories or ecological theories, which supports that the particular movement is influenced by multiple systems. It is not a single system which is working there. Hence, I was very reluctant to get into the technology and think something beyond than what I was doing, because anyways my patients are walking. But when I realized that yes, there is something beyond this, and these technologies are more focusing towards those motor control theories which are being accepted now, and they provoke a multi-system involvement. That is where I started accepting to some extent the technologies. So I want you to understand, I mean, my request you to understand is that whenever you're treating your patients, please ask yourself, am I treating with an approach which is yesterday's, which has not having a good evidence, or I am in today? Am I ready to take a step for tomorrow to integrate for betterment of my patients? Okay. So thank you so much for listening to me, and I hand over to Anuprita to take over the technologies in pediatric physiotherapy. Thank you. Anuprita, go ahead.
Yes, sir. Thank you. And thank you for the kind introduction too.
Yeah, you can go back to your slides. Yeah.
Yeah. So I'm going to focus more on the computer games based rehabilitation platforms that we are experimenting with right now, and which have been used in current research areas regarding pediatric rehabilitation and pediatric neurorehabilitation, to be specific. So what are the areas of concern when it comes to physical therapy today? Today, we need to figure out, while performing one-on-one supervised therapy in a clinical setting, which is the obvious preferred form of therapy because of access and travel and cost for physiotherapy, financial barriers of such, what are the options that we can still provide therapy? For example, there was a COVID pandemic that limited the amount of therapy services that can be provided for our patients. So children with any neurological disorders clearly can benefit from intensive day-to-day regular therapy sessions, but it's not always possible for us to reach out to them or for them to reach out to us. So the transition to home program is something that became very evident during the COVID pandemic. And when that happens, the adherence to therapy, their compliance to therapy reduces very quickly. And there is very little follow-up or very little support we can provide from clinic to their home or to their rural area or to their school setting or to their community setting of any kind. So that was very evident, more so now after COVID. But we have been thinking about this problem and we've been researching about this problem since, me since 2011, and we've been working towards finding solutions to that. As well as the main problem, like I mentioned, is the adherence to therapy. Children are going to get bored of doing the same thing again and again for 13, 15, 17 years of age, ever since they are babies, right? They have been coming to your clinic for that long. They have been receiving therapy. They have been coming to the same room, same setups, same exercises. It gets boring. So we need to find a solution wherein they are not going to not show up for 3 months straight and then come back with more problems or come back the way we have started them with, and all the effort that we have put in and they have put into uh, getting better, having more mobility, having more understanding of movement, just washes away because of low adherence. So then why telerehabilitation? Why technology-based therapy? It's difficult to engage children with neurological issues in therapy for long periods of times and to sustain motivation to keep doing the intense repetitive task practice. So there was a need for therapy interventions that can provide some fun, engaging platform, which is also cost effective, and it can be transferred easily from a clinical setting to a home setting so that we can create platforms at home or in school settings wherein they can still practice, but at the same time we are still able to monitor what they are performing. We do not want them to perform something wrong either just because they are at home. So we realize that having technology in hand really helps with all of the above goals, all of these goals. And we can still monitor child's performance levels. We can still monitor their adherence levels, how often they are practicing the exercises that we have provided for them. We also understood that motor function comes in a package along with other skills, visual-spatial skills, your visual-motor skills, your executive function, your attention span, your sensory motor systems. All of them have to work together. You cannot, in day-to-day life tasks, separate one skill from another. You have to use all of the skills, multiple skills at once to perform your day-to-day things. So the therapy programs that can focus on all the skills at once, let them perform dual tasks and practice those dual tasks without getting bored, keep them engaged for a long period of time, was something that we were looking forward to creating and developing. That's why the focus was on digital media and computer games. In today's day and time, they're readily available in so many markets. You can just go online, type up a few games, and download them for free of cost for $2 or $3 max. For example, if you go to a store, for example, then you can buy a Wii board or you can buy a Xbox Connect and you can start playing games on that very day. And these games can be easily transferred from clinical setting to a home setting, but we as therapists need to educate ourselves how to use them best for our individual clients' therapy protocols. So of course, each game and each therapy protocol, each platform is going to have a separate target population. For example, a 5-year-old is not going to get entertained by a rattle. At the same time, a 1-year-old cannot play Grand Theft Auto. Similarly, different physical impairments and cognitive impairments will allow different abilities to play different games. we have to understand different platforms that are in the market today and that are being experimented on to understand what's the best suited platform for each one of our clients, our patients, to create individualized protocols. So like I mentioned, it is really necessary to understand that multiple systems from our brain are working at once. We are creating different paradigms when we are performing day-to-day tasks. So using digital media can allow to engage these different processing skills using our platform, which is fun and play-based, and it lets children interact with their physical space. So let's say when they are looking for something, they're looking for their pen in a messy desk, or they're balancing themselves while trying to get something off the shelf, or they're walking while talking to you, or multitasking in any way, we can create platforms that will allow these movements to occur as a task while engaging their cognitive space in digital media using fun, engaging games that are very goal-oriented, target-based, that can be chosen based on that person's cognitive abilities. So for this reason, digital media-based dual task platforms were introduced. There are main two types of digital media that we need to look at. One is the motion capture using VR interface, virtual reality interface devices, or the computer interaction using a robot sensor or other sensors and devices. So these devices mainly capture the gross movements occurring at major joints as a response to the challenges that are displayed on your screen, or degrees of movements that you are able to perform. They can be controlled, they can be amplified by choosing the games that require these activities, that require these movements to be practiced. The positive result has been observed in muscle strength, endurance in children who have undergone these protocols with computer games, with VR games, with different platforms that we are going to talk about now. So what is virtual reality? In definition, it is the digital simulation of the real world content. Virtual environment is environment that uses a range of computer technologies to present virtual and artificially generated or augmented sensory information to format in a format that allows the user to perceive experiences, or to allows it to experience real life events as close as possible in an augmented world, in a virtual world. So any kind of virtual reality technology where kids can interact and play with different objects in a computer generated environment can be used for rehab. User interactive device can be a robotic hand or a joystick or other types of sensors, motion sensors, which can interact with the virtual environment, or it can be an immersion method, which utilizes usually a big VR headset that you might have seen, as you're seeing in the screen, with the guy standing in front of a big screen. So there are these two different types of technologies that you can use for virtual imagery. For example, in Grail system, there is a 3D screen that envelops you around the treadmill while you are walking on the treadmill belt, and it has a split belt treadmill. It's a cool device to see, actually. So what kind of games can we play specifically for balance and gait rehabilitation? Commercially readily available games are like Xbox Connect and Nintendo Wii that are excellent for trunk and posture impairments, PlayStation. However, these devices don't really allow too many steps on over ground, or also on treadmill walking. For example, Xbox Connect uses a camera motion-based analysis software, which interacts with the game interface. But these games are excellent for like gross motor function rehabilitation or postural control training in standing. For example, the games that can be used are for like catching different targets or tennis play, dancing avatars, surfing, running avatars, etc. As you may have guessed, that there is a certain level of balance control that's already a requirement, even at a beginner level for these games. So it would be a great tool for hemiplegic kids, for example. However, it does not allow or it does not detect walking. It does not detect sitting. So these are great games for postural control, for trunk control, for upper extremity exercises, for standing balance. However, not for walking, not for sitting, not for fine motor, because it does not give enough accuracy for finger and hand movements. Similarly, Wii Sports Resort gives some gaming options like bowling and air sports and frisbee, basketball. It is very similar to Xbox. This device also does not allow sitting or walking, but it's good for strength training or endurance training, gait control, trunk control, etc. Similar is the PlayStation. All of these you can go to a store and buy it off the shelf and start using. You as a therapist, however, need to understand which of these games are applicable to which protocols. So this is another introductory slide for you for PlayStation. PlayStation is very similar again to your Wii or your Xbox. However, it requires players to use a handheld joystick always. So your hands are not free for holding. So when you're asking them to stand and play these games, please make sure that you have put a harness on them or somebody is there around to make sure they do not fall down. At the end of it though, if you're going to make them go and catch balloons or balls on the screen, would it not be cheaper just to buy a balloon for 5 rupees instead? So then why are we buying these expensive, ineffective, commercially available, expensive devices, right? It's because the interactive nature of commercial online computer games and gaming systems like Xbox, like Wii, they can be an important tool for rehab because it increases the participation, it increases the exercise adherence, yes. At the same time, they improve balance, they improve the fall risk, they improve risk of injuries, which is also an important goal for us in physiotherapy rehab. They are engaging, they're motivating, they provide a very controlled environment, which is not always the case when we are doing play-based or free play-based therapies. Their performance also can be recorded for later on assessments or for viewing later. They can also be created into a trend. It can be used to see analysis after a month, after 3 months, after 6 months, and so on. It can also be easily transferred from your home setting to school setting. Just log into your account and you're there. Your scores are there. You can keep on playing in different environments and still receive the same level of therapy, same idea of therapy. So a recent study which was performed at SDM, actually, we used different sponge pads and different air bladders, balance discs, and so on during dual task exercise program to grade balance challenges in children. So a compliant support surface like a sponge cannot reciprocate the normal forces from your feet as your body sways more as opposed to the ground. So that helped us in creating environments where we can challenge children's balance while they perform these fun, commercially available games, but instead of choosing games from Xbox or Wii or PlayStation, we just went online and downloaded games that were free for play. And we created a low cost version. But of course, not all games are okay to play for all kids. So we had to go through a long list of games, and we created a library of about 80 games in total so far, if I'm not wrong, to choose from, which is a good thing, because the more variety you have, the better it's going to be for the child. Because they get bored very easily. Children get bored very, very quickly, distracted. And also because we need games that will challenge different executive cognitive functions while they are still performing their balance tasks. So that was about balance, and that was about trunk control. How about manual dexterity? How about fine motor control? So far, what we know is that fine motor function impairments are commonly seen in children with CP, in children with different neurodevelopmental disorders. And conventional therapies like CIMT and habit have been created for high intensity therapy programs that can focus on strengthening the motor pathways and high number of repetitions of any given task, instead of low frequency therapy sessions for a shorter period of time. But the problem is, as effective as they cannot be performed long term, because again, adherence is really, really low for intensive repetitive task practice in children as well as in adults. If I tell you right now, pick up a pen and put it on top of your head 100 times right now, you're not going to want to do it. Anybody will get bored. And now trying to do this for 17 years, same movements practice, is going to get annoying. So the adherence will get low is expected. So we needed protocols that are feasible for time constraints too, because CIMT is typically used to be performed for 6 hours a day, which got reduced to modified CIMT protocols, which are 3 hours a day, to habit protocols can last from 1.5 hours to 3 hours, just performing upper limb motor rehab, which again, it's beyond children's mental capacity and emotional capacity and interests in general. It leads to low adherence. So it was necessary to develop protocols that will have all of these components at the same time, will increase their compliance to therapy. So it needed to be fun, it needed to be play-based, it needed to be engaging. So entertaining, motivating protocols, easy way out would be engaging into your computer games. So let's look at some of the published rehab protocols here, which do use computer games based off of these theories. So Ultra was one of such protocols that was created for sensory motor training program, which could be easily transferred from clinical setting to a home setting. So Ultra had been developed for an internet-based upper limb home training program. It combines your arm reaching activities with your compliance to therapy. However, as good as it is to improve the compliance in therapy, the task itself was not high quality. It was reaching and touching the screen, which is not the same as picking up a hot cup of coffee, which is not the same as picking up a cold cup of coffee, which is not the same as picking up an empty cup of coffee. The physical properties that are day-to-day objects give us inputs for sensory information are very important, which are missing in these protocols, unfortunately. Similarly, the robotic handheld devices or robotic devices like gloves and joysticks and wrist and arms, attached devices, joysticks, these are all often fancied by researchers because they look cool, can't lie. But unfortunately, they fit a very small population. When you consider the secondary malalignments and when you consider spasticity patterns and atrophy and things that keep on changing in growing children, these are just not a practical choice. Another protocol that came out was called the Move It to Improve It, or the MIT protocol, which was a web-based therapy program, which is great because then you can access it from anywhere in the world, really. And it uses a Xbox Connect camera, which records the movements, and the game interaction and movement analysis was always recorded, which is amazing. The only issue with it was that it worked perfectly for gross motor movements of upper limb. However, like I said before, the camera motion analysis systems are not accurate enough to understand the wrist, hand, and finger movements. And if you use an actual object in your hand, if you place an actual object, you're handling an actual, let's say, remote control or a joystick, it hides your hand from your camera, which is a very practical problem, I understand, but that also meant that you couldn't actually handle or manipulate any objects while you're doing the protocol. So it worked very well for big joints like your shoulder joint, elbow joint, but it did not work so well for your small joints, and it did not work so well in creating complex movements and manual dexterity, object manipulation. Another robotic handheld device was the U-Grabber. U-Grabber interacted in the virtual environment using motion sensors on your hand. This protocol was based on maximal joint range of motion of small joints of your hands, and also used a haptic feedback or vibration to externally stimulate joint movements. But it did not allow any objects to be manipulated. So the child is not really practicing manual dexterity in terms of handling various sensory inputs. However, it worked well on getting a patient to move your hands and fingers and wrist. So considering all of these pros and cons, we decided to create a low-cost computer game-based rehabilitation platform, which can be used for learning, which can also be used for therapy. And it will also use the principles of goal-oriented repetitive task practice. So this approach combined fine motor manipulation along with gross movements with attention and planning game activities that are based on repetitive task practice, which are appropriate for young children with neurological disorders. So I meant to show you the mouse in particular in this slide. The blue small wristwatch looking thing that you're seeing along with the big blue buttons with the USB is the mouse. It is a regular USB mouse, just works exactly the same as our mouse, except that the mouse cursor moving sensor, we placed it in that wristwatch looking rectangular thing, and the left and right clicks we placed in that long buttons remote control. Now, what we also did is that we made the mouse 3D. So it's an inertia-based mouse which can be placed in the air, and it will still work as long as you're moving it in an angular movement. It will move your mouse cursor. So now if you stick it onto your ball is your new mouse. If you stick it onto your coffee cup is your new mouse. If you stick it onto your pen, you get the idea. So different physical properties of different objects, like different weights and shapes and sizes and friction and surfaces and degrees of freedom in which that object moves. Like, for example, when you're rolling a cylinder versus you're rolling a ball, different degrees of movement. So different object manipulation tasks that would require big joints, like your shoulder joint for a peanut ball versus your elbow joint for your football versus your fingers for your tennis ball. Two finger, three finger movements, wrist and hand movements, all of these can be practiced very easily by just sticking that mouse onto whatever object that you're trying to get your child, your patient to perform. So participants from our study, when we were seeing if the protocol works, seeing the efficacy of this protocol, we asked them to use objects from their everyday life, their favorite toys, their balls of different games that they play, cricket, whether they play football, whether they play basketball, all of their toys, their cutlery from day to day, their cups and school supplies, etc., and instrumented all of them with this mouse, with this motion mouse, to play different computer games. Now, these objects were very wide range, had very wide range of physical properties and required different modes of manipulation and different functional skills, which they needed to practice in order to use them on day-to-day life. But along with that, it was also necessary to choose the right type of games. So we chose online off-the-shelf games that were low cost and that were available just off the shelf. The main focus of this exercise program was to increase the number of repetitions. Typically, each game would be played for 5 to 7 minutes, and every target, if you see in any game, generally one target appears between 1 to 2 seconds. So for every minute, we were getting that child to use that object, may that be their pen or coffee cup or what have you, for 30 to 60 times per minute. So in 5 to 7 minutes, they got hundreds of times of movement performed while using the object in a very precise trial and error manner. They had to be precise. It had to be controlled movement. It cannot be just like waving the hand back and forth. You needed to stop to catch your target at the exact precise position, and over repetitively. And it was goal directed. There was a goal, there was a target given on your screen. To catch that target was the urgency, that was the need. And they were so engrossed in their game, they were so engrossed in getting good scores and moving on to the next step, that they didn't realize it themselves that they have been practicing how to use this object for so long and for so many repetitions, which made it fun, which made it entertaining and engaging. At the same time, it was effective. So the arcade games that most commonly we used usually matched 3 different types of games. There were some shooter games like the Brick Buster games, which are engaging and fun. And there were also the match 3 games. Apart from just looking at how much was your score, your success rate, we also needed to understand that they are using different executive functions. So we needed to make sure that we're choosing a library, from our library, different games that are in particular useful for each one of our participants, each one of our patients. So here are some few examples. Like I said, there are many different types of bimanual and gross motor tasks, as well as some more finer tasks for smaller joints or finger and 2-3 finger functions or whole hand, different objects that can be used in our day-to-day life. But because the IB mouse was a passive game input device, in which you cannot provide a movement assistance to patients using the device itself in, say, a home setting, like you would in a clinical setting. When, let's say, the patient is not able to hold the pen in a tripod grasp, you can assist them, you can teach them. That is not something that was possible for us in a home setting. So that limited us in providing the highest level of therapy, highest telemonitored level of therapy, let's say, for home setting, for community-based setting. For that reason, we also developed a low-cost portable manipulation device, which is robotic, which was equipped with smart monitoring and assistive technology. So the RMD is complementary to IB mouse, but it also provides what we call a tech assistance during game practice for a broad range of manipulation tasks. So the RMD is equipped with a smart movement assistance, which can help after initiation of movement in continuing that particular movement, which are difficult for children. It amplifies the force and helps to continue the voluntary movements that have been initiated by children who are severely affected. So it comes with a variety of handles for practicing various gross and fine movements, and can be adapted easily for providing various sensory inputs by changing different surfaces of the handles. Now, all of this is great, and we needed all of this for providing therapy, for providing treatment, intervention. But we also needed something for understanding how well they are doing, to record how well they are doing. So we needed assessment protocols, we needed outcome measures that can be objective, quantifiable, and can be used remotely for cognitive outcome measures as well as for physical tasks. So before we discuss different objective outcome measures, I just wanted to quickly talk about what telemonitoring really is, because I feel like there's a lot of confusion around it. So what exactly is telemonitoring then? It is, by definition, the use of objective, quantifiable outcome measures for remote assessments. So robotic devices, accelerometers, videography are all described as good objective measures to record movement data of quantitative, reliable measurements of kinematics. And for hand function, you can use it for movements of different kind during recovery. These are automated monitoring tools which are designed for timely feedback of your child to your child and the parent. These outcome measures can see your exercise sessions remotely. You can assess how and when the client is performing exercises, how well they are performing exercises, whether they are experiencing any difficulty, if you need to adjust the protocol because it's too easy or too hard, how well they're progressing in their home programs. In this way, and the parents or children can interact with therapists through a number of mechanisms too, like emails or telephones, or many apps have their own systems to use nowadays for telerehabilitation platforms, for rehab programs at home that have inbuilt embedded telemonitoring devices or outcome measures. So all around the world, in developing countries, in developed countries, many children are not able to receive therapy because of limited access to services, right? So children with entities that are not able to engage in daily school or play or leisure activities will require these services, telemonitoring services. So using telerehab along with telemonitoring can provide play-based therapy platforms for kids, which can maximize the therapy adherence. We have talked about this already, and which can also improve the physical, cognitive, and other aspects of development in children. So what is believed to be a good telemonitoring platform? It needs to be goal-directed. It needs to be repetitive task practice-based. It needs to be able to record the experiences. It needs to record the sessions per se. It can be easily transferred from a clinical setting to a school setting or home setting, has a vast number of activities or movements that can be practiced, and is readily available at low cost. So now, thinking about all the different assessment tools for cognitive measures as well as for physical activity measures, right? So starting with cognition, mainly looking at the executive cognitive function, since that is the most important aspect for performing your day-to-day tasks. We must assess the attention, the reaction time, visuospatial function, processing speed, working memory, decision making, so much more. And while most computer games utilize these functions, most of the games that you're playing with Xbox, Wii, PlayStation do have necessity for all of these functions to work in that child's brain. Unfortunately, most of them only record the scoring, the success rate, and not your processing speed, not your reaction time, not the attention to detail, not the short-term memory span. So conventionally, we have been using many assessment tools for assessing children, for assessing adults of all different ages, for their executive cognitive functions. You may have heard many of these that you're seeing on the screen. For example, MOCA or MMSC. And in the newer ones too, you may have come across these on social media platforms like Lumosity and Happy Neuron, which are great. But unfortunately, they're impossible to perform while you're performing a cognitive or physical task simultaneously, concurrently. Right? So now let me give you a sneak peek at one of the computer game-based assessments that I have extensively been working with so far, and why. So the computer game-based assessment for upper extremity, or we call it the Q assessment, is a versatile tool which can be programmed for assessing different parts of your performance. Of course, you can see the success rate, you can see the score, but you can also see the accuracy, you can also see the speed, you can see the frequency, and it can be adjusted based on each participant for their difficulty levels, for the number of distractors on the screen, changing the paddle size or your target size and speed, and adding different backgrounds and many other components that you're seeing on the screen right now. So when we are assessing somebody, as you're seeing in figure A there, we choose one paddle, that's your mouse cursor. That mouse cursor is going to move to catch all the targets and avoid all the distractors. Mind you, the paddle, distractor, target, size, shape, speed can all be changed along with the background. But when we are considering assessing somebody, we need to have a standardized protocol from point A to B to day 10 to day 15 to day 200, right? So just to remind you of that. So you can see in figure B, different manual dexterity tasks that have been given to the child using RMD or using the ID mouse, and using different objects, different movements. Let's look at figure D first. So when a target appears on your screen, it comes at the top of your screen, let's say. From your top of the screen, if it is falling down to the bottom, it takes about 2 seconds, let's say. So in 1 minute, I have played 30 targets. 30 targets are going to appear, 1 per 2 seconds, right? So then you're going to see that target 30 times. If I decide to create a graph of each time I start moving my paddle, moving my mouse cursor, from the moment it appears, the moment that target appears to the moment that it disappears, is 2-second graph. And now I have 30 2-second graphs there on the screen. In 1 minute, 30 movements that I can assess of this child. As opposed to, let's say, when you're doing PDMS2, for example, you're going to give that child how many chances? 2, 3, 5. Same goes with different other assessments too. As opposed to here, you're giving 30. Similarly, if you see, just to show you what one time event looks like. So when from your target appearance to your disappearance, if you see figure C is a 2-second event, and one graph would look like the way it does here, from appearance to disappearance. And now we have about 30 of them going in both directions. From if the paddle was in the center, everything from up to down going on the leftward, so that your paddle rightward, so your paddle moves to the right. and leftward, right? So these are going rightward and these are going leftward movements. By doing this, we can create graphs to see pre versus post intervention effects. So you can see here, before practicing these tasks, what they look like, as opposed to after what they look like. Once again, going back, if this was your ideal graph, look at how close they are getting to the ideal. Similarly, how consistent the movements look in a healthy adult, or even for children, it would look the similar graph in healthy as opposed to somebody with a stroke. So coming to assessments of balance, right? What you're seeing right now in the video is me playing that exact assessment game we just discussed, standing on a pressure sensor mat array. And as you can see on the screen, my feet moving my center of foot pressure. On the right side of your screen, you're seeing the center of foot pressure from standing still versus when I start playing the game, it starts looking kind of like a spider. That also would change if I'm standing on a sponge or on a balance disc as opposed to a ground. So let's look at the effects of dual task on your balance as well as your cognition, right? When you put that child on a sponge and then ask them to play the game kind of starts looking from here to here, slowly getting worse, as well as the center of foot pressure going from steady to not so steady, unless you keep making them practice this day after day, and then it's going to get better with time. Similarly, when it comes to walking, you should have a system that can tell you exactly how well you're doing from point 1 to point 10, especially in terms of research. So the little butterfly, blue butterfly that you're seeing here is your center of foot pressure moving from point A to point B. So center of foot pressure goes very linearly to your center of mass, more or less. So if you see this slanting line here going from one foot to another, and then again, this foot will go forward, and then this foot will go forward, and this foot will go forward, and it'll create a butterfly. When you stretch that butterfly into ML direction versus AP direction, this is what that butterfly starts looking like. And then you can calculate the spatiotemporal gait parameters based off of your graphs for each individual patients. Luckily, you don't have to do any of this personally, because we all, when as researchers create these systems, we create analysis systems along with it that'll help you come to the conclusion, come to the spatiotemporal gait parameters readily without having to work for it. So you have it in your hand. Here I'm just using a different type of technology. So earlier, what you were seeing was a pressure array mat. As I mentioned, here I'm using a HP Cosmos treadmill, which uses a force plate under the treadmill belt. But you can still see similar butterfly. Obviously, the one at the top looks a lot better than the one in the bottom. The one in the bottom is kind of crooked. That is because of a neurological impairment in a patient. Just to give you a visual of what DT cost looks like, the dual task cost looks like in patients. So here in the first video, I'm walking without performing any game. You can see my steps are pretty consistent. Whereas now with playing games, you can see my steps going completely haywire. That is the effect that gets put onto your brain when you're doing two things at a time or multiple things at a time, when you're using your executive cognitive function along with your physical task. Why this is so important, why we should focus on this, is because in your day-to-day life as a child, as an adult, as a neurologically impaired person or as a completely normal adult, you are going to have to perform day-to-day life tasks using multiple systems at once. So at the end, what were the benefits of using this kind of technology-based rehabilitation platforms, and what were the challenges? So many inexpensive, easily accessible, common games, modern games are now available in the market. They all exist. They're visually fun, they're rich, they're engaging, they can include different varieties of spatial, visual spatial tasks and cognitive tasks. They have a lot of choices, which is great. Good variety is always something that we need when we are creating protocols for children. They are goal directed and engaging and repetitive task practice based, which is all great. But they do require a certain amount of training for the physiotherapist, and it requires a operating system which cannot comes at a price, and it cannot perform all of the tasks. Like even the smallest amount of tasks that we have performed till now using technology cannot cover everything. For example, buttoning and unbuttoning, or tying shoelaces. Those are things that we haven't been able to integrate in therapy protocols using technology yet. So then why, at the end of the day, why choose CGR with assessment protocols for therapy? So what we have understood is, if we have the understanding of therapeutic value of these therapy protocols, the therapeutic objects as well as games, then it can really help the therapist to prescribe individualized programs for their patients. Commercial games have wide range available for levels of different precision, different movements, speeds, amplitude, direction, accuracy, you name it. It has a wide range of executive cognitive activities also, along with wide range of motor sensory activities as well. So it just provides therapists with a standardized method of quantifying task performance for prescribed home exercises as well as clinical exercises, with or without direct in-clinic supervision, as in telemonitoring, along with telerehabilitation. Thank you. That was my last slide.
Thank you so much, Anuprita. That was a really elaborate and very insightful presentation for everyone. And I could see that the participants persisted with their presence, and I'm thankful to all the participants as well. A few important points that you mentioned. And before I mention the points, I'm proud of what you people are doing as a part of increasing the technological base, because what I understand is the development of technology is not going to stop. How we bring it to rehabilitation depends on the need that we create, the opportunities that we provide for the designers, for the technologists, and I'm sure the inputs that you are providing are going to go a long way. So we summarizing, Sanjay started with a few questions of going back to the roots of why, what, how, yesterday, today, and tomorrow. And I think very rightly you ended the presentation with a few solutions and creating a right balance between the traditional based and the technological based rehabilitation. But still, there are a few questions on the availability, the costs, and the applicability to patients and their functions about the use of technology. And I would leave the presentation now with questions and discussions if participants have any.